But as we transition down the eustachian tube and into the throat, it is a completely different kind of engineering challenge.
Very much so.
It is way less about delicate reconstruction and more about managing a chronic biological battlefield. We are looking at the throat's gatekeepers, the tonsils and the adenoids.
These are our frontline immune defenders.
Yeah.
But the surgical protocols make it clear that there's a tipping point where these defenders actually become the primary threat.
Right, and historically, getting your tonsils out was almost like a casual rite of passage.
Oh yeah, everybody got ice cream.
Exactly. But today, the criteria for a tonsillectomy are incredibly stringent.
Incredibly strict.
Like, the absolute indications require a seriously documented track record of systemic failure. You need more than 7 episodes of severe tonsillitis in just 1 year.
Which is a lot.
Or more than 5 episodes a year for 2 consecutive years. Or more than 3 episodes a year for 3 years. They don't just extract them for a bad sore throat anymore.
No, they really don't.
Though they also list obstructive sleep apnea, or OSA, which makes structural sense if the tissues are physically expanding and blocking the airway during sleep.
Right, but the contraindications, the exact scenarios where you absolutely must not operate, are equally rigid.
Yeah.
Some are intuitive, like the patient is under 3 years old or currently has acute tonsillitis.
Oh, yeah.
Operating on actively inflamed hypervascular tissue basically guarantees massive, uncontrollable hemorrhage.
Blood everywhere. But one contraindication really caught my eye, and it feels almost like a ghost from another era.
The polio one.
Yes. It says epidemic of polio. If there's a polio outbreak in the community, you immediately cancel all tonsillectomies.
It does sound like a historical relic, but the biological mechanism behind that rule is terrifyingly sound.
Really? How so?
Well, the tonsil bed is incredibly rich with exposed nerve endings, and the polio virus specifically targets and attacks the nervous system.
Oh, wow.
Yeah, if you surgically create a massive open wound full of raw, bleeding nerve endings in the back of the throat during an active polio outbreak.
Just inviting it in.
Exactly. You are essentially rolling out a red carpet for the virus to march directly into the central nervous system.
Just opening the fortress gates? That's wild. And the complications they list for the surgery reflect how brutal the extraction can be.
It's not a gentle procedure.
Not at all. There's primary bleeding, which occurs in the first 24 hours, and secondary bleeding occurring after 24 hours.
Yeah.
But then there's this mechanical risk, TMJ dislocation. They can literally dislocate your jaw joint during the surgery.
Yeah, that is a direct mechanical consequence of the intense pressure applied by the surgical mouth gags.
The metal instruments they use to pry your mouth open.
Right. These heavy metal instruments are used to forcefully pry and keep the airway open to expose the surgical field. And remember, the patient is under general anesthesia.
So they're paralyzed.
Exactly. Their jaw muscles are completely paralyzed and relaxed, offering zero resistance to that extreme mechanical leverage.
Yikes. Just yikes. And situated right behind the tonsils are the adenoids.
Yes.
The grading system for adenoids ranges from grade 1 to grade 4, based purely on how much of the choana, which is the opening at the back of the nasal passage, is physically blocked.
Grade 4 meaning complete obstruction.
Right. And the surgical removal methods listed are intense, blind curettage, where they use a sharp loop to scrape the tissue away without direct visualization, a coablation, or using a microdebrider.
Very aggressive techniques.
But I have to push back on this whole concept. If the tonsils and adenoids are critical immune organs, why are we using these aggressive, tissue-destroying methods like lasers or diathermy to obliterate them? Isn't it completely counterintuitive to aggressively vaporize your own immune system?
It is a massive biological trade-off that surgeons weigh heavily. But it comes back to that tipping point we discussed.
The 7 infections a year.
Right. Early in life, yes, these tissues are vital for sampling pathogens and building an immune database. But when a patient hits those strict criteria, the physical architecture of the tonsillar tissue has fundamentally collapsed.
Yeah, it's broken.
It is no longer a functioning defender. Its deep crevices have become a starred, pitted harbor for chronic bacterial biofilms. The organ itself is actively poisoning the host.
Oh, gross.
Yeah, so the methods like radiofrequency or lasers are utilized because they simultaneously cut and immediately cauterize the tissue. That seals the blood vessels to minimize that severe hemorrhage risk you mentioned earlier.
Ah, okay. That makes sense.
Oh, and regarding adenoidectomies, you skipped over a particularly terrifying structural complication.
Oh, right. Atlantoaxial subluxation.
Exactly. The adenoids sit directly in front of the upper spine. If the surgical extraction causes severe deep tissue inflammation in the back of the throat, that inflammation can actually spread backwards.
Into the spine.
Yes, into the ligaments holding the top 2 vertebrae of the neck together, the atlas and the axis. Those spinal ligaments become inflamed and lax, and the top of the neck can literally misalign.
It is deeply unsettling how interconnected it all is. Okay, transitioning from those active immune battlegrounds, we move further down into the neck itself. And here we shift from managing active infections to dealing with the structural ghosts of our embryonic development.
It's a fascinating area.
This section of the protocols is full of developmental quirks and hidden couches that create incredibly strange physical symptoms. First up is the pharyngeal couch.
Mechanically, this is a focal weak spot in the muscular wall of the pharynx, sitting just above the esophagus. Over years and years, the high pressure of swallowing forces the inner mucosal lining of the throat to bulge out through this muscular weak spot. It creates a literal sac hanging down into the neck cavity.
And the symptoms are highly specific. Patients present with severe dysphagia, regurgitating completely undigested food, sudden weight loss, and a chronic bowel taste.
Guess who gets trapped?
Exactly. But the most memorable symptom listed is a gurgling sound in the neck, which has the fantastic medical name, cervical borborygmy.
Describe the term.
Reading the mechanics of this, the best analogy is the U-bend pipe under a kitchen sink.
Oh, that's a great way to picture it.
Right, it's supposed to be a straight vertical drop down to the stomach, but instead you've developed this trap that catches debris and food just sits there rotting, which leads to that foul taste and that distinct gurgling noise when the patient drinks water.
That is exactly what is happening mechanically.
Yeah.
And the modern treatment highlighted in the protocols is a brilliant piece of engineering.
What do they do?
Well, instead of performing an invasive open surgery on the outside of the neck, they utilize endoscopic stapling.
Okay, stapling the throat.
Yeah, they navigate down the throat with a sterilized scope and deploy a stapler that simultaneously cuts down the dividing wall between the pouch and the esophagus, while immediately stapling the raw edges closed.
So it flattens it out.
It converts 2 separate tubes into one wide funnel. It's quick, bloodless, and allows the patient to resume eating almost immediately.
But pouches aren't the only structural anomalies in the neck. The texts extensively detail various cysts.
Yes, cysts are very common here.
There's the thyroglossal duct cyst, or TGDC, which typically presents right in the midline of the neck. To correct this, surgeons perform the cyst trunk operation. But the explicit warning is the risk of injuring cranial nerve 12, the nerve controlling the tongue.
You definitely don't want to hit that.
No. And then there's the branchial cyst, which the text notes contains a straw-colored fluid saturated with cholesterol crystals.
Well, what's fascinating here is why a branchial cyst exists in the first place.
Great, where do they come from?
The protocols reference theories of origin, like the branchial apparatus theory. These are direct references to our embryonic development. When we are embryos, we develop these structures called branchial arches, which structurally mirror the gill slits of fish.
Wait, gill slits?
Basically, yeah. During normal development, they fuse seamlessly to form the architecture of our face and neck. But sometimes, a tiny tract fails to seal.
Oh, I see.
Decades later, that microscopic, unsealed remnant of our embryonic past can suddenly fill with fluid and swell up into a massive cyst in the side of the adult neck.
That is wild. Our inner fish just popping up in our 30s to say hello?
Exactly.
Okay, for our final section, we shift from the internal plumbing failures to the external casing, the skin. and the vital airway.
Right, the boundaries.
This is where we look at how our biological boundaries handle environmental exposure. Let's look at the airway bottleneck first. Subglottic stenosis.
This is a pathological narrowing of the airway just below the vocal cords. It is structurally the narrowest part of the pediatric airway. And if it scars down from trauma or intubation, every breath becomes a severe physical struggle.
And the mechanical interventions listed range from using precise lasers to excise the obstructing scar tissue to balloon dilatation.
Which is pretty forceful.
Yeah, where they literally inflate a high-pressure balloon inside the airway to forcefully stretch the cartilage open, or even injecting Botox to paralyze the constricting muscles.
All viable options depending on the severity.
But moving outwards to the skin, the protocols dedicate significant focus to surface threats on the head and neck, and they break down the exact mechanisms of major skin cancers.
Which makes perfect sense when you consider the sheer volume of environmental radiation sun exposure the skin of the face and neck endures compared to our internal protective system.
Right, it takes beating. They detail SCC, or squamous cell carcinoma, specifically highlighting a type called a marginal ulcer. This is an aggressive cancer that arises directly from old burn scars. Then there's BCC, basal cell carcinoma. The protocols vividly describe this as a rodent ulcer because it physically presents with these distinctive raised, rolled edges, making it look as though a rodent has been gnawing away at the skin.
Very descriptive term.
Very. And finally, melanoma, which the text bluntly labels as highly metastatic.
And this is where understanding the why is so critical for a surgeon. A marginal ulcer forms in a burn scar because that scar tissue lacks a normal blood supply and is trapped in a continuous cycle of microscopic cellular damage and impaired repair.
So it's just constantly trying to fix itself and failing?
Exactly. Over years, that chaotic cellular environment triggers malignant transformation. And a basal cell carcinoma develops those rolled edges because the cancerous cells are aggressively multiplying at the outer margins of the lesion. They're physically pushing the skin up into a ridge while the center ulcerates and collapses.
So I guess the big question is, what does this all mean? When you step back and look at this entire stack of surgical protocols from diagnosing a rolling border on a rodent ulcer to perfectly aligning a 0.5 millimeter titanium piston inside the skull, the sheer scale of what these surgeons are tasked with observing is staggering.
It reinforces the absolute necessity of critical, hyper-detailed observation. The human body is a masterpiece of engineering, but when it fails, whether through environmental exposure, embryonic remnants, or mechanical wear and tear, it always leaves physical clues.
Yeah.
The surgeon's entire job is knowing exactly how to read the mechanics of those failures.
That is beautifully put. And that brings us to the end of our journey today. We have decoded some truly incredible medical texts, covering everything from bionic titanium eardrums and the microphysics of pericusis to gurgling U-bend throat pouches and the exact biological tipping points required to justify a tonsillectomy.
It really is a remarkable look at the structural, mechanical reality of the human body.
It is. And I want you listening to this right now to just take a second and think about the incredible, fragile machinery operating inside your own head and neck at this very moment. As you hear my voice, your microscopic ossicles are vibrating, your immune tissues are standing guard, your airway is constantly adapting to the pressure. It's an absolute miracle of biological engineering.
A miracle that requires constant, delicate balance to survive.
Exactly. And I want to leave you with a final thought to ponder, building off what we learned today about the sheer delicacy of the inner ear. Given that our middle ear bones are so astonishingly sensitive that a fraction of a millimeter of mass determines whether you can safely fly in an airplane,
Right.
how might our increasingly loud, constantly pressurized modern environment with earbuds jammed in our canals for hours a day be subtly altering these ancient mechanical structures over the course of our lifetimes? It's something to think about next time you turn up the volume. Thanks for joining us on this deep dive. Keep questioning, keep learning, and we'll catch you next time.